International. I would like to welcome you to the Towards Transforming Ethiopia's Primary Healthcare System webinar, where we'll hear key lessons and successes from a 5-year plus USAID flagship primary healthcare activity, which Pathfinder led in partnership with the Ministry of Health and implemented alongside JSI Research Training Institute, Abt Associates, Encompass, and the Ethiopian Midwives Association. We will hear from a number of colleagues from the Pathfinder Ethiopia, including Dr. Mengistu Asnakai, Country Director, Dr. Bekalai Balayahun, Senior Research Advisor, and Dr. Luam Teshumai, Technical Director for FP, Family Planning and Gender. Please, before we start, a few practical notes. Please put the question and answers in the box, not in the chat, and they will be directed to the appropriate speaker during the Q&A section. This presentation will be conducted in English and French with French interpretation. So for French, please click the interpretation icon, which you will see indicated by a global sign on the menu bar, and select French. A link to the French version of the presentation will also be added to the chat once the panel begins. So I'm now delighted to hand over to Lois Quam, who is the CEO of Pathfinder International.
Thank you so much, Catherine, and good afternoon, all of our colleagues at Pathfinder Ethiopia, and good morning, good afternoon, and good evening to Pathfinders around the world. I'm really honored to be with you today. In 1966, the late Ethiopian Emperor Haile Selassie met Pathfinder staff and committed Ethiopians. He gave tacit approval to begin working on family planning in Ethiopia, but cautioned the group to keep a low profile and to find a non-controversial name. This early start resulted in a small seed grant from Pathfinder to form an Ethiopian organization and open the first family planning clinic that eventually became known as the Family Guidance Association of Ethiopia. And I remember in my first visit to Ethiopia after I joined Pathfinder, going with Dr. Mengistu to meet with some colleagues and seeing the picture of that first clinic in the middle of 4 dirt roads. Our work greatly expanded in 1995 with the opening of Pathfinder's Ethiopia country office, serving an area that encompassed most regions of the country, including serving people living in hard-to-reach rural areas. Taking a community-based approach to reach the country's most underserved people, Pathfinder collaborated with local NGOs, the public and private sector to deliver training and commodities and services in reproductive health, family planning, maternal and child health, and post-abortion care. Through a network of more than 10,000 community-based reproductive health agents, as well as 47 local NGO partners, Pathfinder has provided information and quality reproductive healthcare services to more than 3.5 million people in its first 10 years of services in Ethiopia. Pathfinder also developed and strengthened these NGO partners, creating lasting resources and sustainable development programming across the country. Pathfinder's early work in Ethiopia was pioneering and is still characterized by that spirit today. We have a long history of partnership with government to bring high-quality services to millions of Ethiopians living in underserved areas in different parts of the country, and we've done that for 25 plus years. Commencing in 2017, the USAID Transform primary healthcare activity built off the Pathfinder-led Integrated Family Planning Family Health Project, IFHP, and the new Primary Healthcare Unit, PHCU, structure to strengthen and manage the performance of Ethiopia's national health system. The aim was to improve quality of service delivery across a continuum of primary health care, improving household and community health practices and health-seeking behaviors, and strengthening program learning to impact policy and activities related to the prevention of child and maternal deaths. This activity partnered with the Ethiopian government, USAID, and other in-country implementers to institute a flexible, responsive, and innovative primary healthcare system, as you will see presented. Across the country, Pathfinder has worked to strengthen health infrastructure, train and mentor the health workforce, and ensure that all people get the care they need, including maternal and newborn care, cervical cancer screenings and prevention, and reproductive health care. Pathfinder has also been a key player and partner to the government in cervical cancer prevention. Our programs integrate cervical cancer prevention activities with HIV/AIDS treatment and care, maternal health, and sexual and reproductive health activities. There continues to be numerous opportunities for CCP intervention for women in Ethiopia. Pathfinder is grateful to USAID and the Ethiopian government for their continued support and partnership in implementing these activities. Pathfinder is so grateful to all Pathfinders Ethiopia for the success achieved, the impact delivered over these past 5.5 years of implementing Transform. And I'm very pleased to introduce our esteemed colleague, Pathfinder's Country Director in Ethiopia, Dr. Mengistu Asnaki. In many ways at Pathfinder, he needs no introduction. His dedicated services in Pathfinder Ethiopia over 20 years, culminating most recently in Transform, and the way he has provided guidance to me and the other leaders of Pathfinder across the whole globe is precious and is so important to our organization. Menge, I'm pleased to hand it over to you and to thank you for all your leadership at Pathfinder.
Thank you very much, Lois, and thank you for the excellent introduction in terms of our program in Ethiopia. Good morning, good afternoon, good evening, colleagues attending this webinar from the different corners of the world. Thank you for choosing to be part of this important session. As introduced earlier, I'm Dr. Mengistu Asnaki, the Senior Country Director for Pathfinder International in Ethiopia and the Chief of Party for the USAID Transform Primary Healthcare Activity, which is the topic of our session today. At the first part of the presentation, I'll focus on providing you some background of the activity, some of its strategies and approach used. This will be followed by a deep dive on the use of data in the activity for evidence generation and knowledge management by Dr. Bekele Belayhun, who is the Senior Research Advisor of the activity, and Dr. Luam Teshome, our Technical Director, will share the outputs, outcome, impacts of the activity, including adaptation, challenge, and I will finally summarize by sharing our key lessons and takeaways. Next slide. The USAID Transform Primary Healthcare Activity is a bilateral agreement between the US and the Ethiopian government in preventing child and maternal deaths in line with the Ethiopian Health Sector Transformation Plan. The activity started in January 2017 and will end in September 2022. It's a cooperative agreement with Pathfinder International, worth of 120+ million US dollars. Prior to the start of the activity, a co-creation process was done that formed the basis of all achievement and lessons learned to be discussed partly in this session. The process of co-creation involved the staffs of the consortium, USAID, other donors, different levels of the Ministry of Health, and other partners implementing similar program, which really helped to design a successful plan in response to the priorities of the health sector transformation plan in preventing child and maternal deaths. This was followed by the development of detailed plan through a theory of change exercise in all the implementation regions jointly with the public sector and partners working in those implementation regions, and the final plan at the national level. In addition to that, there is an inbuilt monitoring, evaluation, and learning platform in the activity, and a separate evaluation setting from baseline and midline was awarded by USAID to Transform Mala, and now the inline evaluation is being finalized. Both the baseline and the midline were used as an input to the activity to shape up its work plans and adapt to any of the changes happening within the activity. Next slide. The activity focused on 4 major areas that includes health system strengthening, quality of services, the whole issue of behavioral change and practices, and program learning. And each focus area as one result area, and also have different sub-results. In the first result area, major emphasis was given in performance management and improvement, leadership, management and governance, health information system, healthcare financing, and sub-grant management. In the second area related to quality of service delivery at primary level of care, that includes the primary hospital, health centers, and health posters, were supported through capacity building trainings, mentorship and coaching, quality improvement projects, innovative approach, provision of gap-filling equipment and materials, and selected renovation of facilities to improve the quality of services. Under the third result area, the community facility linkage and demand generation for increasing utilization of available reproductive, maternal, child, adolescent health services was included. The last result area, but not least, more focus was given to promote continuous learning, adaptation, and enhanced impact in preventing child and maternal deaths. The learning outcomes from the activity were used to contribute to the improvements within the project and contributions to both national and global level evidence and knowledge. Next slide. The USAID Transform primary healthcare activity was implemented by a consortium of diverse partners that bring excellent on-the-ground knowledge and ability to respond effectively to challenging and implement activities covering over 16 different thematic areas that range from family planning, reproductive health, maternal health, newborn health, child health, immunization, malaria, and a lot of several cross-cutting issues such as gender, the performance management and improvement, the health information system, the healthcare financing, social behavior change and communication. But in all this, the program learning was included as one of the thematic areas. The core consortium partners include Pathfinder International as a prime, GSI Research and Training Institute, Abt Associates, Encompass, and the Ethiopian Midwives Association. And for the first 3 years, Malaria Consortium was part of this activity. Additionally, we used different resource partners who brought a range of both Ethiopian experience and innovative thinking were part of the activity on using demand-based technical assistance. Next slide. The activity has been implemented, as you can see in the map, over the past 5+ years in 6 regional states, namely Tigray, Amhara, Oromia, SNNP, Sidama, and Southwest Ethiopia. And it was able to touch the lives of around 57 million people in 451 targeted waradas, or equivalent of districts. Within this geographical area, 118 primary hospitals, over 1,800 health centers, and over 9,300 health posts got direct support from the activity. Next slide. The activity used several strategies, which includes the phased and adaptive technical assistance, by looking into the progress of activities and performance of waradas, the technical support was tapered to these sites which were high performing progressively, and sites with an ability to transition from mid-performing to high-performing were given intensive technical support as we move our implementation over the years and reduce the technical support and also the lower level presence by shifting it to higher level technical assistance. Different innovative approaches were integrated specifically to address the equity gap to hard-reach areas such as the integrated periodic outreach services and the integrated backup support for family planning and other services, which really helped to reach those hard-to-reach segment of the population. Again, harnessing the whole issue of existing mechanisms and investment, we built on existing investments by government and other partners rather than duplicating efforts. So this was very helpful to create complementarity rather than duplicating similar activities, and also using already existing experiences and lessons to build on that. Again, most of our implementation were linked to public sector-led initiatives, which helped a lot in terms of creating sustainability. The activity already on some of the innovative things to be implemented by the government, and mostly supported the flagship programs of the government, such as the immediate postpartum family planning, the integrated periodic outreach services, and others which are very important. And this also uses government structures, which is really important in terms of enhancing the capacity, the HR capacity of providers and also managers at the different level, with the goal of the activities to continue after the project ends. Again, another important strategy is the gender integration. Anchoring gender in all the activity result areas was an important strategy through which gender analysis and action planning done, and every thematic area or every result area really uses the gender analysis to implement the different activities. One other important area where we actually put in a different color, maximizing development and humanitarian nexus, is a lot of emergencies were responded in this activity using our rapid response and also crisis modifier budget in addressing specifically the immediate needs of the emergency, and also creating a partnership with the humanitarian agencies, which helped in terms of reducing or avoiding duplication of effort, and also maintaining essential health services during times of crisis, which really created a maximization of development and humanitarian nexus. In implementing the different core strategies, the annual theory of change, which I mentioned earlier, was a very important strategy, which we did an annual strengths gap analysis and also partners mapping, basically to leverage resources and avoid duplication of effort before finalizing our yearly implementation work plan. In all our activities, the whole issue of collaborating, learning, and adapting is a key approach. And in addition to that, we have a continuous monitoring, evaluation, and learning, where having an inbuilt system to regularly monitor and follow progress of activities and review every quarter for corrective actions was one of the strategy used in this activity. Next slide. The activity used an integrated and holistic approach based on the life course along the continuum of care, and the different thematic areas well integrated with several of the cross-cutting activities, such as the health system strengthening, the community-based health insurance, gender, nutrition, social behavior change, our innovation activity, and the sub-grant process, all of them helping the whole issue in the holistic approach. In addition, through the life of the program, response were given to health emergencies and crises by basically minimizing the impact on fatalities and also containment of the rapid spread in case of communicable disease. Next slide. The activity has introduced several innovations that were very useful in enhancing the results gained under different thematic areas. As you can see in the slide, a lot of issues related to setup improvement, the process innovation, and the technologies introduced, which were at different levels of the health system. To mention few examples, the family planning exercise contributed in improving planning and resource allocation for family planning, specifically at the district or Warada level. The VISCAN, the mobile ultrasound, which helps for early diagnosis of anomalies and timely referrals from health center to hospitals for care and increasing uptake of antenatal care. Again, the integrated and on-site training saves time and money. Solar suit cases were very important in availing services 24/7. So I will pass the presentation to Dr. Bekele to tell us a little bit on the use of data and generate knowledge and expanded ownership. Dr. Bekele, the floor is yours.
Thank you, Dr. Mengistu. Greeting everyone. My name is Bekele. It's a pleasure to speak with you today about using data to generate knowledge and expand ownership. And I'll try to highlight how we created a smoother ride using data. Next slide. Everyone in data use and knowledge generation activity is involved in taking the right action at the right moment. So the program people, it starts with getting the right people involved, which is much larger than just a regular MN system. And program and technical teams are started to define equation for data collection tools. And they try to make sense of data now, what question to ask and help to identify adoption. And the MN team, then the field team also collects the data related to different thematic areas, and they try to review and use and present the data findings. And the monitoring evaluation team facilitates data collection orientation and also facilitates the review meetings. They provide support to the cluster team, guide the direction of where the conversation is going, and facilitate for further analysis, including developing a dashboard and synthesize the findings. And all the team members are come together quarterly review meeting to learn and determine the adoption actions. And the government people, they try to support us to prioritize and facilitate the connection between knowledge and insight that is emerging to larger priority areas and tech stakeholders. And also the donor who have influencing to give more flexibilities and shift resource and expand budget, and also providing guidance on the scope of adoption of the projects that can be supported. All teams are continue to disseminate the knowledge through different channels, and we all take a tangible action to improving the service progress and see the progress of our effective effort to look at where gaps are existed and where those gaps can be closed with a clear evidences. Next slide. And we try to look at the same maps, use the same system and structure. And through looking the same maps, we conducted a field visit to take to track the implementation progress over the previous activities. And we started every technical review by conducting a field visit and revising the annual theory of change exercise. This helped to us enforcing our shared and agreed upon the goal, and also support us to discussing the big pictures of the anchor, and it ensures the action items are aligned to bring us closer to our desired end status. These all things are serve as our guide and roadmap for getting to where we ultimately want to go, and serve as reminder to look at the big pictures of the intervention. And we also shared everyone responsibilities in the project expected to set the data, and it also check it and use in the dashboard. All the technical teams are responsible to define the question based on the data collection tools, and they also review data that can be collected, and they used the data from the dashboard for annual planning, presenting a plan for performance and technical update. And all the field teams are, every cluster coordinators and officers plus the regional officer are expected to review, process, analyze the data they will present, and working with the data system. They can also creating different dashboards to make sense of all the data sets they have. And the country office Pathfinder team may provide the technical support with these steps, but the cluster and the regional staffs are expected to own this part of the process. Through the process, the government and the donors, based on the dashboard and the evidences, they provide regular input and propose to align with the government priorities. And the team, we also visualize this dynamic process that is involved in everyone over time. And we are also committed to learning with humanities. Next slide. And the team scan all the lenses for information with switching the layers. We see our technical review as a chance to scan all available information. We use multiple sources of the information. We are also considering the routine and random follow-up data we have. And we also use the dashboard and survey data and the partner and the community feedback experiences to help us understanding what is happening and what we already know in the activities. And before beginning the implementation of the project, we conducted partner mapping with different partners in the region. Some are excellent in some skills and some go through the process. Others are not interested to learn and collaborate and stand alone and see what is going on. Some partners are strong working and 2 or 3 programs together. In Transform, many health domains are integrated and working together with experienced and highly calibered partner with considering all the beneficiaries, children, mother, adolescent, and all others. These are important to change some contexts, and it is also important to struggling the activities of the fragmentation. This is a beauty of working together with the support of technical review meeting is to show how much an integrated project has been contributed for the bigger pictures of the national achievement. Next slide. So we are driving hybrid vehicle to encouraging sustainability through capacity building. So the partner, we provide different technical supports, including establishing regional knowledge hub. We provide different program learning capacity building activities. So we are also generate multiple evidences through based on different thematic areas, which are contributed for strengthen evidence based for policy decision, which also contribute to optimizing the implementation and sustainability, sustaining effectiveness of available intervention. We support or contributed for the innovation to generate tools to achieve program objectives. And after generating all the evidence, we try to share the evidences through program publication, through reviewed journal and web-based publication. More than 64 conference abstracts are presented in national and international conference. These things are contributed to the national communities by sharing new knowledges. And one of the things to be ensuring the sustainability is adapting. And we try to adopt based on the evidence of the program learning more than 10 adapted program learning have been used as an input for the national policies and strategy formulation over time. This is some of the highlighted presentation about how we are using the data and generating evidence. Then the next presentation content presented by Dr. Loam will share the output, outcome, and impact of the activities, including the adoption of changes. Dr. Loam, over to you.
Thank you, Dr. Bakala. Greetings, everyone. I will continue highlighting some of our outputs, the results we've gained from implementing this activity, outcomes, and impact level changes that we have contributed in preventing maternal and child mortalities. Next slide, please. So at the output level, one of our major interventions is capacity enhancement activities in the different thematic areas that have been listed earlier. So we have trained more than 112,000 health providers. Majority of them are health extension workers, which are our frontline health workers, which are deployed at the community level. Then our major output, the second one, is setup improvements. We've been working introducing different mechanisms to improve the setups of our health facilities. One of them is more than 1,200 maternity waiting homes have been supported to be functional. That was very useful for mothers to deliver in health facilities with skilled assistance. We were also able to provide more than 2,000 health facilities with gap filling materials and equipments to initiate services and also to fill some of the gaps. This was mainly on the family planning program. And for the adolescent and youth, we were able to expand youth-friendly health services in more than 400 health centers, which was very useful for the majority of our population, which is a young population, and services were provided using those youth-friendly service provision health facilities. The other area we have worked on as an output is improving processes. We have introduced, as you have seen, different innovations, and just to mention some of them, the quality improvement interventions have been introduced in more than 700 health facilities, and they were able to design change projects, identifying their challenges and addressing those challenge areas in their context area, and they were able to contribute to improving quality of care in those health facilities. And the other major area is also in identification and referral of confirmed fistula, obstetric fistula cases. More than 80 plus years, and they were referred to treatment centers for management. And this was very useful because the mid-level health professionals were able to confirm those diagnoses and refer those which was very life-changing for those individuals. And the fourth area is on the sub-granting. Close to 22 million USD was dispersed to grantees to implement different activities based on their challenge area or gaps identified. They designed intervention areas and implemented interventions to improve the maternal and child health services at regional, zonal, warada, and primary hospital level. And the other major output is on the expansion of the community-based health insurance. We're able to support the enrollment, which has increased from 115 schemes to 353 in the last 5 plus 5 years. And these are the major outputs. Going to the outcomes, next slide, please. We were able to reach close to 60 million adolescents and youth on SRH information related with family planning, STI for HIV screening, pregnancy testing, and linkage to ANC service for those who were pregnant. And out of which 6 million of them were able to access those services. And one of our intervention areas was post-abortion care. We were able to reach more than 13,000 adolescents and youth with this service provision in those supported health facilities. And looking into the skilled deliveries, more than 3.3 million mothers were able to get a skilled delivery service in those facilities we've been supporting. And looking into the child health component, more than 3 million children were able to be treated for pneumonia. Next slide, please. So with all those outputs and outcomes at the impact level, we were able to contribute in prevention of unintended pregnancy for more than 80 million for more than 8 million of unintended pregnancies were prevented, more than 85,000 maternal mortalities were averted, and related to the infant mortalities, more than 894 infant mortalities were averted because of the interventions introduced by this activity. Next slide, please. So while we're implementing those activities, there were so many challenges encountered, and we have also implemented some adaptation mechanisms to respond to those challenges. One of the major challenges was the shortage of family planning, shortage of commodities related to family planning, maternal and child health. So although the project was not able to procure those specific commodities, we were able to liaise with the government and implementing partners working on the supply chain to as much as possible to fill the gaps, technically supporting, and also in health facilities where there is excess commodities, we were able to shift based on the guidance that's provided from the Ministry of Health. The other major challenge we have encountered is ongoing conflict. It has been happening in all our intervention regions, and the recent one is in the northern part of the country. And to respond to these needs by the government, we were able to use the crisis modifier budget to respond to the acute emergencies, working with the humanitarian partners. And also we reprogrammed the year 6 budget of the activity, which was very useful to restore some of the services which were interrupted because of the damage happening in those health facilities. The other major challenge we have encountered is the high staff turnover. Trained staffs were leaving those health facilities because of different reasons. This is not the challenge of this activity only, it happens to all project interventions with other implementing partners also. But to address this challenge, one of the mechanisms we have introduced was on-site training, which was easier to perform, more efficient, and the gaps were addressed using this mechanism. The next major challenge we have encountered is Warada splitting. Initially, when we initiate the interventions in our intervention regions, the number of Waradas was 300, but over the years it has grown to more than 450. And this was due to the splitting of the Waradas due to different factors. So we were able to address those issues, like focusing in those areas which needed intensified technical support with the weaker Waradas, which are willing to change. We have been our focus areas to address this challenge. And as you all know, the major challenge is also ongoing COVID-19 pandemic, and other outbreaks has also happened, like malaria, cholera, and others. So we were able to flex and use the crisis modifier budget to respond to those emergencies. And in the meantime, we were also able to maintain essential health services, working closely with the government and other partners. Next slide, please. So this slide shows some of the photos while we're doing the handover activities to the war-affected health facilities in Amhara region. Specifically, we were able to provide those facilities different medical equipments, including laboratory materials, which has helped to restore services, especially focusing on maternal and child health services. And it was very useful and appreciated by the regional and the Ministry of Health. The next presentation will be done by Dr. Mengistu on the lessons learned. Over to you, Dr. Mengistu.
Thanks so much, Dr. Luam. I will briefly highlight on some of our lessons and some takeaways before we conclude the presentation. Next slide. Several lessons can be picked from the activity, and for this presentation, we'll only focus on very few of them. And one thing is the whole system level support, specifically at the Warada or district level, and creating a facility linkage can really be a useful mechanism which can drive a creation of more high-performing facilities, health centers, health posters under the districts. Again, the whole issue of mobilizing local resources, our family planning exercise was very useful for Waradas really to understand and allocate budget for some of the family planning services in their Waradas. The twinning partnership between high-performing and low-performing districts, between facilities, was very helpful, really using domestic resources in terms of creating better achievement in the health services. I have already said a little bit earlier in terms of the response to emergencies was very helpful to really ensure continuity of essential services. In the past, whenever there are crises, everything from the routine services was shifted to respond to the emergencies. But having dedicated resources to respond to emergencies was also another important lesson from this activity. The whole issue of the gender integration, specifically the gender analysis during planning, budgeting, was very useful in really making practical gender mainstreaming activities in the different levels of the health system. We said a lot in terms of introducing technologies, both in terms of creating better effectiveness and also the outcome of different health outcomes and results in terms of improving health is a very important thing. Research, not for the sake of really having evidence for the purpose of careers of individuals, but the research for program improvement by really generating evidence the programs can use for decision making, but at the same time, it can be shared for better knowledge and learning at a national level or even beyond that. Again, the sub-granting was another important area which has created better capacity in project proposal development. Specifically, some of the waradas or zones were able to diversify their funding by using the experience they got from the sub-granting process, and it also helps a lot in improving performance. Next slide. When we do all these activities, we did that sustainability in mind from the start of the project. We didn't start to think of sustainability at the end, but we were able to really make sustainability to be part and parcel of any of the design at the start of the program. So we feel like the lot of capacity improvement or capacity enhancement done in terms of putting trainers pool, improving training sites, providing new trainings to be integrated into any of the national documents. That's very helpful to really create sustainability. Again, the sub-granting, which I mentioned earlier, it increased the capacity of waradas, not only to improve their performance, but also to really have a resource diversification capacity by writing good proposals and go to different donors. The planning exercise, I said the family planning exercise specifically was very helpful in generating local resources. The new initiatives and technologies, some of them are being owned and become part of the national policy documents and started to be scaled up, which is one sign where the ownership and sustainability is really being seen. Again, some of the government ownership and social commitment are also signs for the sustainability. Next slide. What are some of the takeaways? First of all, in doing such activities, I think we need to think of an end-to-end approach. And this end-to-end approach, specifically, it's very critical in strengthening the capacities of the health system at all levels. And this should not be a one-time activity. It should be a continuous process. There should be learning and adaptation in the process. And in doing this, we need to have an evidence-based program adaptation. And the activity having an inbuilt MND and also collaborative learning and adaptation strategy was very helpful in doing that one. Again, the co-creation, the annual theory of change, the partners mapping, and those all partnerships are very helpful. And having a participatory planning from really the start of the project can also contribute both for sustainability and also for the outcomes. The whole issue of an integrated holistic approach rather than small vertical programs, and that holistic approach is very helpful and more efficient and effective mechanism to deliver services. Last but not least, the whole issue of humanitarian development nexus is a very critical, specifically in a country like ours, where there are always man-made and natural disasters. There is a need for development programs to contribute in minimizing suffering, morbidity, and deaths in coordination with humanitarian actors. And that nexus is a very important thing to really continue essential services and to help in maintaining the development gains of the country. With this, I will ask the organizers to show us a very short video, which will really give us a highlight of what we presented now. And after that, Catherine will facilitate the rest of the session. Thank you.
In 2015, Ethiopia launched its Health Sector Transformation Plan 1 to build on its significant gains in improving healthcare in the last decade. A key focus of the plan was preventing maternal and child deaths. To support this goal, the United States Agency for International Development, with additional resource support from the Korea International Cooperation Agency, devised what was to date the mission's largest integrated health activity in Ethiopia, the USAID Transform primary healthcare activity. Supported with several other resource partners, the activity is implemented by a core consortium of 6 organizations: Pathfinder International as prime, JSI Research and Training Institute Inc., Abt Associates, Encompass LLC, the Ethiopian Midwives Association, and Malaria Consortium. The activity, which was operational from January 1st, 2017 to September 30th, 2022, strengthened Ethiopia's health system by enhancing the capacity of district and facility leadership, supply chain, and health information system for primary level care. Its work has increased the utilization of quality health services, including family planning, antenatal and postnatal care, labor and delivery, and child health to improve health outcomes for women, children, youth, and their families. The activity also introduced, tested, and scaled up several life-saving innovations. Close to 58 million people across 451 districts, known as Woredas, have benefited through the support provided by the activity to 118 primary hospitals, 1,860 health centers, and 9,347 health posts within the Amhara, Oromia, Sidama, Southern Nations, Nationalities and Peoples, Southwest Ethiopia, and Tigray regions.
The government of Ethiopia set its goals of preventing maternal and child deaths as stipulated in the Health Sector Transformation Plan. USAID also shares this goal in its global programming, develops health projects to address critical challenges in maternal and child health. So the USAID Transform primary health care is one of these, addressing maternal child deaths in Ethiopia. Co-designed through a theory of change exercise that engaged regional and national representatives to define regional and Woreda level health priorities, needs, and also potential actions. So USAID has provided technical and financial support as well as oversight for the last 5+ years.
Based on the previous experiences that the Pathfinder and the JSI and others have gained, building on the experiences and also improving the management, the performance of the health system. That was the key, and focusing on primary health care, the district health offices, zonal health offices, health centers, and health posts, and the primary hospitals, and above all, the community engagement component.
USAID Transform Primary Healthcare's legacy will continue through adaptations of programming in both public health and conflict-related emergency management and public sector ownership through subgrants for sustained impact. Additionally, response to health emergencies like COVID-19 prevention and vaccination rollouts will ensure the country's health system is able to absorb any future shocks. Ultimately, the USAID Transform primary healthcare activity created positive and lasting changes that contributed to strengthening Ethiopia's health system.
Thank you to all of the presenters. And I see there's lots of questions coming in now into the Q&A box, and because of time, we'll touch on a couple of those, but rest assured that there will be an email following this session, which will provide a comprehensive response to those that we don't get to. So one for Dr. Mengistu, you mentioned a rapid response and crisis modifier budget. Could you tell us more about this mechanism and how it played a critical role in responding to the COVID-19 pandemic in Ethiopia and ensuring sustained access to services? Was the project Nexus from the start or pivoted to respond to the humanitarian crisis?
Thank you so much, Catherine. And this is an excellent question. First of all, considering our experience and also the ministry from the past, when we designed this activity, initially there was an allocation from the government sub-granting in terms of, there were 3 sub-granting channels, one for performance improvement, the second one a breakthrough to support innovation, and the third one was a rapid response fund. The rapid response fund was basically to respond to any emergencies. It can be communicable disease, crisis related to, natural or man-made disasters. So, including some of the pandemic like COVID-19. So initially it was a rapid response fund. Later that name was changed into the crisis modifier budget. Every time, whenever those things happen. In the past, whenever an emergency happens, most of us as development partners, we were not responding to it. Rather, we try to get emergency partners or humanitarian partners to come and respond into that one. The other option is the government district or the region will reprogram their routine activity budgets to respond to emergencies, which clearly tells you that in the first option, the response might be delayed. In the second option, you get your resources to be transferred into emergency and you have minimal activities or routine activities. So you might even end up in a cycle of emergency. When you tackle one, the other may start because you didn't do your routine services. So the addition of this rapid response or crisis modifier budget into the overall activity budget helped us to respond to those crises immediately. In terms of the overall project works in terms of prevention, but the rapid response helps in terms of immediate response, which resulted in containment of spread for communicable diseases and also for minimizing fatalities because of some of these issues. So it's part of the design, and also in any of our recommendation, what we said is this approach needs to continue. Any of our development activities need to have a dedication of a certain amount of resources to respond to some of these emergency crises.
Great, thank you, Dr. Mengistu. And I see some meaty questions in there around attribution and sustainability, which we may not have time to delve into right now. But one for Dr. Lewin. What was the coverage of the Transform project overall? For instance, in the regions where we were operating, was it 50%, 100% of the region? What percentage of the population, to give us a sense of the scale of the project? Thank you.
Thank you, Catherine. Out of the 11 regions, we're covering 6 regions in Ethiopia. Looking into the population coverage, as you have seen on the first slide, more than 57 million catchment population was covered by this activity. It is almost, considering the projected Ethiopian population, which is around 110 million, it's almost half of the country's population have been covered by this activity.
Great, thank you very much.
Probably to add more on that, in the districts or the zones we do, if more or less we are doing, like for the district it's 100% coverage, and in most zones 100% coverage, but in some of them there were some waradas which were not covered by our activity.
Thank you, Dr. Mengistu and Dr. Lurum, for those clarifications. So many thanks to all the presenters. As we've heard, the Transform programme was able to achieve a great deal towards transforming Ethiopia's primary healthcare system, which will have an impact for many years to come. These accomplishments would not have been possible without the leadership of the Ministry of Health at all levels, the support and guidance of USAID, and the harmonious collaborative partnership with all of our consortium partners, as well as the dedication of the staff who work tirelessly to deliver all the necessary activities and ensure their success. It should be noted that these accomplishments, and indeed the developmental strides of the government of Ethiopia, must be sustained, and the work is not yet done. Pathfinder is committed to the next phase of this journey, to build on the achievements made so far and to scale up best practices for coverage and sustainability in line with the government key priorities. If you'd like to know more about the Transform programme, we'll be sharing a recording of this session, as well as other resources and a Q&A and all of the answers to the questions that we didn't get to follow up in this session. And this will come through an email to all registrants. So thank you very much for joining us today, and enjoy the rest of your day. Thank you very much, everybody.